Super. Well, thank you so much, Amy and Scott. And I'm going to just share my screen here. Okay.
Perfect.
I am so pleased to be here. Thank you, Phillips, for the invitation to be on this webinar and talk about a topic that's near and dear to my heart. And for all of you listeners out there, I saw some familiar names. So hello, it's good to see you on here. And this is a long webinar, so I want to leave enough room at the end to have some question answer. And by all means, Scott and Amy, feel free to interrupt me if a question comes in through the chat. All right, we'll get started. So I'm going to talk about pedal duplex and pedal acceleration time. Here are my disclosures. Probably my biggest disclosure is that I have this deep passion for limb preservation and feet, as Amy said. And so I always love it when we get these complex foot wounds coming in to sort of sort out the issue and collaborate with our team. So why do we care? Why are we giving this webinar? Well, we're a part of this team. And for all of you vascular technologists and sonographers and providers out there, we're facing a huge problem. And patients with diabetes, renal failure, their amputation rates are high. And it's a good reminder that following an amputation, 50% of patients will die in 2 years. And what's even more staggering is when they have an amputation, that usually the other limb will follow. Guys, and in our diabetic and renal failure patients, we look to toe pressures and maybe even TCPO2. However, I find more and more these patients don't have toes, and so we're limited. So then we go to a full arterial duplex, which is an incredibly powerful study, but historically, we've stopped imaging at the level of the ankle. And the patients today need more. And that's why I'm so excited to talk about this topic, because as a sonographer, we can now image into the foot and provide far more information than we ever have. If you're familiar with the global guidelines, I love this figure because this figure really helps us think about where the disease patterns are going to be. We all do a comprehensive history and physical before we even start our duplex. But this gives you a really nice look. And I highlighted the diabetic and the smoker because the minute I know a patient's got a foot wound and they've been a diabetic for 30 years and never smoked, I know in my mind that the majority of the disease is going to be from the popliteal down. Conversely, if they're a smoker and a non-diabetic, I can anticipate the disease to be more aortoiliac, common femoral SFA pop. So I'm already thinking in my mind what I'm going to find. So I actually queried our patients for the last couple months, and this is them. These are not old cases. I put together a new talk because I wanted to freshen things up to say that we are still facing this problem. So yes, we have all of this great diagnostic testing, but these patients need and deserve more. And for all of us doing ultrasound, we can play a very integral role in the decision making and really problem solving to what's happening with these patients. So I'd like to give you a historical vignette about PAT and really how pedal duplex was born. Back in 2017, this is Dr. Tesso. He's a vascular surgeon that I published with and worked closely with for over a decade. And this was our first case using pedal acceleration time. And this was in August. And at that time, I had scanned my own foot and discovered I can see all of the blood vessels in the foot. And we actually looked at pedal velocities, the waveform analysis. We did calculated flow volume ratios, but really acceleration time was the most sensitive. And for this first case, it was like extraordinary that we actually could see the change in acceleration time on the table. And we could see a real physiologic change with duplex ultrasound of the foot. So this was a big breakthrough. And then, of course, we've had multiple publications that have led to more research. So for this talk, we have a lot to cover. We're going to talk about anatomy, perfusion, pedal flow hemodynamics, and I'm going to give you a quick down and dirty step-by-step guide. I have 2 cases to share, and then we'll talk about emerging use of pedal duplex, and then, of course, the multidisciplinary team, which we are all a part of. And I had this patient, actually was my patient yesterday, and this patient is my age, I'm 46. And so this patient, highlights that we need to know and do more. So let's start with anatomy of what we can see with duplex ultrasound. So the image on the left, this is an oblique view of the pedal arch. Just to refresh your memory, is that this is what we can see with ultrasound. And yes, there's a little blind spot in here, but we can see the majority of the pedal arch. So if we come down through the anterior tibial artery, as we cross the ankle mortise, and if you look here on the anterior circulation, right as we cross here, we have 2 little branches, the medial tarsal artery and the lateral tarsal artery. Oftentimes they're pretty small. It continues down to the dorsalis pedis artery. And then if you feel your own foot, there's a bone right here that's called the cuneiform bone. Just distal to that cuneiform bone is a soft window between your first and your second toe, and it kind of sits right here. So this is like, we use windows for TCD. This is called the cuneiform window, and this is this really beautiful space that we can see the arcuate, the arcuate artery and the first dorsal metatarsal artery. So that makes up just like the standard anterior circulation. When we look at the posterior circulation, as we cross below the medial malleolus, the medial plantar and the lateral plantar will bifurcate. And then if we look at what that looks like on the bottom of the foot, the medial plantar is more superficial and kind of heads right to that first met head. And then the lateral plantar will head more to the mid to lateral foot and then connect up to complete the entire pedal arch. Now there's a superficial arch in there. It's this connection right here. But, in the majority of patients, this is what we see. So this is a nice review of anatomy and what we can see with ultrasound. And this is what it looks like angiographically. So the medial plantar artery is generally smaller in caliber. The lateral plantar is more dominant and robust. And then here's that little tiny blind spot that we can't see between the bone. But when we talk about hemodynamics, you'll be able to see that we can indirectly infer that the arch is intact or not. So the anatomy part of pedal duplex imaging is super important because sometimes it answers the question. So like this patient, the amputation site's not falling apart. And when we put a probe on there, the lateral tarsal artery is very robust and dominant, and it just courses laterally here. And maybe this is an anatomical variation. There was just no vessel, and just tiny little collaterals fed the first dorsal metatarsal artery right here. And we'll go over criteria, but the PAT here is very bad. So it makes sense that maybe not, the problem is maybe not up here, but it's an anatomical issue. So we've talked about anatomy. Now let's move on to acceleration time. This is an objective number that we can quantify perfusion in the foot. So PAT is essentially the extension of the arterial duplex scanning into the foot. It can be done at the bedside, intraoperatively, postoperatively, and throughout the course of wound healing. And essentially what acceleration time is, it is measuring the time it takes a red blood cell to get from point A to point B. So if you have no obstruction proximally, these red blood cells are going to move fast, and you're going to have a fast upstroke of your waveform. If there is obstruction and disease, you're going to see a slow acceleration time of the waveform, and your acceleration time will get longer. So our criteria has been published in the Annals of Vascular Surgery in 2019, and we looked at 499 limbs that we put against normal ABIs. And these are patients that had no diabetes, no renal failure, that ABIs were reliable. And this is how the 4 classification got developed. But PAT not only correlates with ABIs, but it correlates really beautifully with clinical symptoms. So class 1 PAT is an acceleration time of less than 120. Class 2 is long distance claudication. Class 3 is short distance claudication, less than 2 blocks. And then class 4 is significant and it correlates with tissue loss and rest pain. So we know that if you're in the class 3 to class 4 PAT, you have hemodynamically significant disease and you have not enough blood flow to the foot. So this is the most important slide of the entire talk, is that how we measure acceleration time accurately. And for those of you on the call, you've probably used acceleration time in other beds of the body. Acceleration time is nothing new. We've used it in the distal renal arteries, the carotid, the common femoral artery. We're just applying it now to the foot, which is a high resistant bed and appears to be more reliable. So the technique is to lower your baseline down, all the way down. We're going to increase our sweep speed because we want to see 4 cardiac cycles. We're going to increase our waveform, so decrease your scale. So the waveform is big, and even just overgain it a little bit, because we want to accurately measure from the onset of systole to the peak of systole. So we would not want to measure from this baseline. You have to measure from the onset of systole. And with your ultrasound calculation package, you will then have a time, which is going to be right here, and you apply that time to the criteria. So over the course of the last 5 years, been very exciting and a lot of work, but so amazing. We've had many publications, and now we're starting to see people publish outside of our group. Now we see the French Canadians publishing this recent paper, and a group in Brazil just published this paper in the Journal for Vascular Medicine. So it's getting very exciting, and I encourage all of you to, if you are into research, please contact me. There's so much to uncover here and correlate with PAT. So I work with Dr. Montero Baker at Hope, and that's in Houston, Texas. And we just did a podcast together on Back Table. And he coined this ultrasound first approach. And it is so true, because the innovation of ultrasound, thank you, Phillips, has come a long ways. And the criteria was developed, and I used an Epic system. And so ultrasound really is this powerful, powerful tool that we can use now. We're no longer in a proximal, mid, and distal world. We are now locating, isolated disease, vessel sizing, scanning the foot. We can do so much with ultrasound. So ultrasound really should be the first line of testing in patients with CLTI. And yes, we can do CT and do an angiogram, but we get a really nice understanding and snapshot using duplex ultrasound. So this is what I love about it, is we have changed our protocol, and I'm just talking about wounded CLTI patients. I want to be really clear about that. I start in the foot every time, because right away, you will know if it is normal or abnormal. So for example, the patient on the left, this is a neuropathic foot wound. The PAT is class 1. So this is not a vascular problem. I can relax and sit back in my chair and just start scanning. Where the patient on the right is class 4, and now my posture changes, and now I'm going to get serious, because now we got to map out this patient. This is class 4. It kind of sets the tone. And really, in our office-based lab in Portland, Dr. Constantino is like, she is on it. Right to the front desk, we have class 4. Let's get this patient going. So it really wastes no time. And now I can slow down and really do a comprehensive duplex. Amy, someone raised their hand. I don't know if we want to take that now or later.
Yeah, I got that. That was an accident.
Okay, good.
So
just interrupt me.
Thanks. Yep.
Okay. So now that we've scanned the foot and the alarm bells are going off, we know it's really bad. Now we're going to do a comprehensive duplex ultrasound. And if anybody's heard me talk, I can't say enough for a diagram. I think that numbers are really hard to follow, and it doesn't always tell the whole story. So when we look at this patient, big deal. They've got profunda lesion, they've got a popliteal occlusion. All of that can be fixed. Yes, we have inflow, we can't go up and over, but really what's more interesting is what's happening in the foot. If we were to just stop at the ankle, this is not inline flow to these toes. This patient's perfusion pattern is coming down the posterior tibial artery, around the lateral plantar artery, through the arch, indirectly through the second dorsal metatarsal artery to get blood flow to the toes. So it's really interesting to know this, because when we do the intervention, we can open this up. We may need to really clean up this posterior tibial artery to optimize blood flow, because indirectly the pathway is going towards the posterior circulation. So I feel very strongly about this comprehensive mapping, and it really adds to the whole picture of how we're tackling these complex patients. So we've talked about anatomy, we've talked about PAT and how we measure it. Now let's talk about pedal flow hemodynamics. So you have to know the flow, and this is so fun because just like think about the circle of Willis and put it in your foot. Like there's so much that can happen with the high grade, ICA lesion, and how the communicating pathways happen around, the circle of Willis. It's kind of the same concept in the foot. So there's all these variations of what we can expect when we scan a foot. So when I put the probe down on this patient's foot and I see retrograde flow from the arcuate artery, I know in my brain, number one, the arch is intact because it's retrograde flow. Number two, I know that flow is coming from the posterior circulation, and I'm likely to encounter disease in the anterior circulation. Same thing happens here. If I put the probe on the lateral plantar artery and the flow is retrograde, I know that the arch is intact and that I'm going to encounter disease in this posterior tibial artery circulation. Where we get a little fooled is when we have a situation like this, where we have single vessel runoff via the perineal artery and the AT and PT are occluded, but we have antegrade flow in both the lateral and arcuate artery. And when that happens, I know that we have really nice communicating arteries off the perineal artery. And the perineal, I always think, is like the profunda, or, is the lifeline of the lower leg. And it gives rise to these really amazing collaterals that we see angiographically, and we can see them with ultrasound now if you know what to look for. So as long as you understand the foot pathways, you can almost indirectly suggest what's going to happen when you start scanning the limb. And this work has been published. They've put in classification systems, but now we can put actually ultrasound around these classification systems. So this is currently in progress as well to correlate with this classification system. And really, people around the world are really loving PAT too. Dr. Patron in the UK, single vessel runoff PAT is great when it's just the perineal is open, because the beautiful thing about PAT is it captures collateral flow. So you can have single vessel runoff with normal PAT as long as that collateral flow is well established. Dr. Isa in Spain, and I agree with him, this is an essential tool for patients with CLTI.
So Jill,
yeah,
we do have two questions here.
Great.
I can jump in with you. Some of your great pictures brought up the comment about recommendations for probe covers for open wounds or wet gangrene.
Yeah, so I started switching to them. I use a probe cover if I'm going to get close. To be honest, I rarely scan over a wound. If I do, it's certainly going to use a probe cover, or if I'm even getting, close-ish. So yes, I mean, by and large, we should probably always be careful, but oftentimes I'm just on the skin.
Okay. And there is a question about how severe would a stenosis expect to be or need to be in order for a change to be seen with the ABI exam below the knee?
Sorry. So is it if there was disease in the foot?
I'm assuming that doesn't specify.
Okay, so maybe they're thinking is that if the ABI is normal, will we see changes in the foot? The answer is yes. And there's a lot more disease that happens in the foot than I think we realized. However, there's also all of this hemodynamic patterns. Our foot compensates. So you can have an occluded lateral plantar artery and your medial plantar artery will get really big and kind of take over. So it just depends on the pattern. But yeah, I think the nice thing about, PAT is it kind of just tells you how significant or severe that stenosis would be.
All right. And we'll hold the rest of the questions until the end of the presentation so that we won't have those on the recording. So I'm going to turn it back to you.
Okay. So this is an example of pedal flow hemodynamics. So if we orient ourselves correctly, this is scanning on the top of the foot. The indicator of the probe is towards the patient's head. Here's the patient's toes right over here. So here's that cuneiform bone that's sitting on top of your foot. Already we know based on our color scale that this is a retrograde arcuate artery. So already I know that the pedal arch is intact and flow is coming from the posterior circulation. And the PAT is normal. That's totally fine. This patient's dorsalis pedis artery was occluded, but because flow can indirectly reroute through the arcuate artery out the dorsal metatarsal artery to the great toe, this patient's totally fine. It's class 1 PAT. So my point is that we can have normal PAT with antegrade or retrograde flow. You just have to kind of understand the flow pattern. So this is really an important point to make is people have a lot of questions about interpretation of PAT when you have varying classes of PAT numbers. So if you have normal or almost normal PAT on the top of the foot and very abnormal on the bottom of the foot, I'm going to tell you, well, the arch is probably not intact. And the number that you would want to use is the number, the PAT value that is closest to the wound bed. If there's no wound, you want to report out the highest or the worst PAT value to reflect the foot. So I'll say that again. If there's a discrepancy of numbers with like major classification differences, look at your flow pattern. This anterior tibial artery is widely patent. So is the arcuate artery right here. If this was intact, we should see retrograde flow in the deep and lateral plantar artery, but we don't. We see antegrade flow. So what this PAT is so bad, it tells me that the communicating artery is probably not very big and probably there's disease in the perineal or somewhere. So you just, it's really nice to get the piece of paper out, draw the foot, draw the arrows around, and you can really start to like frame your mind of what the flow pattern and what the numbers actually mean. But pay attention to the PAT closest to the wound bed to report out. Okay. Sorry, the value of PAT, my screen is blocking it. This is really nice because it answers the clinical question really fast. Is this a vascular problem or is it not? And it really can expedite care. Sometimes these diabetic patients sit in the hospital for days, more like a week, because we don't really know what to do with them. And we can say, nope, this is a vascular problem. They need intervention now, or this is a neuropathic wound. This is not a vascular problem. So we can decrease the length of stay. And then I believe it can decrease the rate of higher level amputation. I'm working with really incredible physicians around the world, specifically in El Salvador, where the amputation rate has decreased dramatically because we have this new tool. Just because they have a terrible wound doesn't mean we always need to amputate. As long as there's no infection, we can be patient with these patients as long as their PAT is in good range. And sometimes these wounds don't look that bad, but this little wound here is like the canary in the mine. If you look at this duplex, the flow to this foot is 2 centimeters per second. This is going to fail fast. So, and with a good duplex, like we can fix this, whether it be open or endo. So this is a step-by-step guide, kind of like down and dirty. Like, how am I going to do this study? I want to try it tomorrow in the lab. Okay, so I always start with the anterior circulation. We're going to put the probe in a long axis view, indicator towards the head. So we're going to do the same thing every time. You're going to put it in that little soft tissue window. And right away, we're not going to apply any color. Just use B mode, because if you're in that window, you want to just fan your probe a little bit, and you're going to see the cuneiform bone. You're going to see medial marginal veins. And now we know we're kind of in the right territory. So here's the distal dorsalis pedis artery. This is the first dorsal metatarsal artery going to the great toe. Pretty beautiful. Now we can apply color. And we already can see that this is antegrade and the arcuate artery is retrograde. So now we can start to do our tests. We can start to get our PAT values. Now we teach 5 sites of the pedal arch because in a wounded patient, you have to just really know it. It's like you can't teach TCD and just get the MCA. You have to know it all because there's different disease patterns. So when we look at the top of the foot, you're going to look for this waterfall view of the arcuate artery, and you're going to see it crusting over the same way every time. So we're going to take a PAT right here, and then another PAT in the first dorsal metatarsal artery. I love the first dorsal metatarsal artery because if you have a toe wound, this is amazing. This little vessel is so easy to scan, and it's very superficial, and it'll tell you so much information. So we've already gotten 2 PAT values, arcuate and first dorsal metatarsal artery. Now we're going to go to the posterior circulation. And a lot of people are like, I have a hard time with the bottom of the foot. And I agree. Sometimes it can be tricky. So what we're going to do is we're going to start in a transverse view in the bottom of the foot. A lot of people ask if I follow down the posterior tibial artery below the medial malleolus. You can, but I do not trace them as it courses through the heel. You can Doppler in the distal PT and then pick up your probe and put it right on the bottom of the foot. So we're going to go in a transverse view right in the bottom of the foot, midfoot. And now we're going to identify our landmarks. So this is the metatarsal bone. And just like the calf, we have vein, artery, vein. So we can identify the lateral plantar veins and artery in a cross-sectional view. And just like the calf, we can do compressions, and you can say to yourself, yes, that definitely is the lateral plantar artery because I see the metatarsal bone and I see the lateral plantar vein around the artery. Now, luckily for us, the lateral plantar veins are huge in the majority of patients, unless they have some, post-thrombotic issue. So this is the lateral plantar vein, and then this little guy here is the lateral plantar artery. So use the veins as your landmarks. Super helpful. And use your color as well. So we want to decrease our color scale and use those veins. Even if you have to augment the calf a little bit, they'll light right up. So the deep plantar, when we think about like SFA to pop, it's a name change. So it's sort of the same thing with the lateral plantar to deep. The reason I like the deep plantar is if the lateral plantar artery is occluded and the arch is intact, you will see retrograde flow in the deep plantar artery. And so it kind of just tells you that the arch is intact, but the lateral plantar artery is occluded. So the deep plantar will just dive because remember, it's going to meet the anterior circulation. So we're getting as close as possible to the anterior circulation from the bottom of the foot. Now we're going to move on to the medial plantar, and sometimes it can be really challenging to find. The medial plantar is typically smaller in caliber, and it's going to be more superficial. Medial plantar is so important for these patients with met head wounds. It is exactly where you want to go. So if this patient had a diabetic ulcer right here, I'm going to put my probe right here on the medial plantar and get a PAT. You know you're on the medial plantar artery because you want to look for this medial fascial band. And if there's any MSK people out there, I would love to know the true name of it. I just call it medial fascial band. But the medial plantar and vein is just going to be just superficial to the fascial band. And then you know you're on the medial plantar artery and vein. And the medial plantar vein is usually smaller in caliber than the lateral plantar vein. So that will help you too. So some common questions that you might have is, how do I learn? So again, Hope Hope Clinical Innovation Center in Houston, Texas. We are developing the Hope Academy, so that will be a future site for training. And then how long does this extra exam take? I mean, really, it's like an extra 10, 15 minutes in a complex CLTI patient. If there is no wounds and you're just getting, just the anterior and posterior circulation, it's like 5 minutes. Like anything, once you're good at it and you understand it, we can be fast. And I think you'll find it very enjoyable. Actually, it's kind of fun. Can we bill for it? The code that we use is 93926, CPT code in the US. And that's a limited arterial duplex, but you can't, if you're going to do a full arterial duplex, you can't bill extra. It's just sort of embedded in. But where it becomes really helpful is, let's say a podiatrist or a surgeon, someone does a toe amputation and an intervention, and they come back for their follow-up and they're like, oh, I'm not really sure if the wound's kind of stalling. Now I'll do a limited arterial duplex and bill for that code, and it'll take like 20 minutes. So it's a nice billable code. I think it's about $150 in revenue there. So I have 2 case illustrations. And so let's go through these. These are more recent cases. The first case is an 82-year-old male. He presented with a non-healing left first-ray amputation site. This is like such a common story. He's diabetic and he wore his shoes wrong and he developed a blister on his big toe. And we all know the story. It just ends up in not a good thing. So again, he's diabetic. His A1C was like 8. He's had bypass, so he has no GSV for any conduit, and he was a prior smoking. So I'm like, oh, he's gonna have disease everywhere. He's had prior left SFA stent at an outside institution, and so podiatrists send us this wound here. So you can bet the first place I'm going to go is on the top of his foot because I can't wait any longer to know what's happening. And so he has, I'll show you the image here, but continuous flow in his foot. I'm going to come back here, but this is what the arcuate artery looked like. And so when we see this, someone would say like, well, how do you know that's not vein? So if you see this in the foot, go to the distal AT or PT, because look, this is the distal AT. So this patient automatically has class 4 PAT because you can't even measure it. So with a full arterial duplex, of course, he's got his SFA, he's got stents, and his SFA pop is occluded with single vessel runoff via the perineal artery. But the nice thing about this is he has patent communicating arteries through the anterior and posterior communicating artery off the perineal artery. So he has forward flow on both sides of his foot. So again, very poor flow. I was could measure a waveform on the lateral plantar, but really it's just flat. So I just want to show you here. Here's the lateral plantar vein. Here's the little artery. So, and then here's the metatarsal bone. So the imaging that I show you sometimes is beautiful and sometimes it's not. I mean, it's like any other vascular bed. We just have to use all of our tricks and tools to optimize the system. So the patient went on for intervention, of course, antegrade access to the common femoral artery. You can see his stents are occluded. We got through, did atherectomy, balloon angioplasty through those stents. He still has a residual lesion of his TPT, but single vessel runoff, perineal artery. And, this perineal is my favorite artery. Look at this beautiful communicating artery going to the posterior circulation, and then a smaller one on the anterior circulation. So this was his foot shot during the case here, and looks pretty good, right? But this is not objective numbers. And so I scrub in and we do intraoperative duplex with our cases. And you can see his arcuate artery on the table is now a PAT of 133. We are now getting close to a class 1 and we are done. And this is really nice because it is an endpoint and it's an objective number in complicated patients. So we have our data published. We know the number. PAT is a predictor of limb salvage. So we know when the PAT value is 180 milliseconds or less, that is predictive of wound healing. And that's outside of any major infection. So we have a target on the table to say, are we done? And that is really powerful. So now the patient comes back. Remember, it was 133 on the table. Oh, 133, 120 at his 1 week post-op. So with the full arterial duplex, got a residual TPT lesion here, but this doesn't look too bad. And now we can go to the podiatrist and say, the blood flow is good. Of course, what are they going to do with it? I'm not sure, but from a vascular standpoint, we can give solid numbers to say this patient is optimized at this moment. We need to do something because this doesn't look great. Okay, here is case 2. This is a 55-year-old male who presented with a non-healing left hallux wound after, unfortunately, dropped a can of grocery or something on his toe, and he's had his other toe amputated too. So he's diabetic. He has all the multiple comorbidities. He was a prior smoker. He's had interventions on the right side, but never on the left. So of course, the first place we're going to go is right to the dorsal metatarsal artery and see what his PAT was. Well, that wasn't helpful because it was occluded, as you can see from my drawing. But just like I said, if the lateral plantar artery is occluded, usually the medial plantar will be open. So on the top of the foot, if the first dorsal metatarsal artery is occluded, usually the second dorsal metatarsal artery will kick in and provide flow. And that's what happened here. But the PAT is still poor, it's 200. And with a full arterial duplex, of course, he's got this tight, lesion in his popliteal artery with tibial disease as well. He was mapped. This patient was done after the best CLI. So we always map all of our patients, great saphenous vein, in the event that bypass is a better choice. So they always have that option. And then I'm also always mapping the tibial arteries for pedal access every time, and also looking at what the best option is for groin access and sometimes even radial. So when we start to think like an interventionalist, like a surgeon, it can really help in case planning for optimal success of these patients. So here's what an occluded dorsal metatarsal artery looks like. Again, here's that cuneiform bone. Here's that first calcified dorsal metatarsal artery that's occluded. But if I scan down a little bit, here's that second dorsal metatarsal artery, and it just tracks right up here, and we can get a PAT of 204 going right to the great toe. So I was just going to share with you what does ultrasound look like. Here's this common femoral artery. This looks fine, multiphasic flow in the SFA, even in the distal SFA. And then, of course, we should be suspecting something. So he's got this high-grade lesion of his popliteal artery. And I love duplex imaging because it really can, maybe help the interventionalists with device choices. We can do on-the-table vessel sizing for balloons and stents. And, there's so much information that we can provide that can help them with their decision-making. They can have all the stuff pulled before the case is even started. So this patient went on for antegrade access down the common femoral artery. Of course, very nice correlation is chip shot case, right? So high-grade popliteal lesion confirmed with IVUS. So did atherectomy and balloon angioplasty of that popliteal artery. And unfortunately, the little occlusion here in the proximal posterior tibial artery that we couldn't get through, tried and tried. But really, we needed to get flow to that second dorsal metatarsal artery. So AT was fine. We just optimized the perineal artery. But, to use intraoperative ultrasound, the foot doesn't even have to be sterile. Sometimes I'm just bouncing back from clinic and I just need to put on some lead, but I'm monitoring this second dorsal metatarsal artery throughout the case. And in this case, it went from 200 to 217 or 117, so class 1. And I'm looking at a really tiny artery, and we can even be precise enough to say, we're done. So the patient has follow-up, had a partial toe amputation, and didn't have the wraps taken off of his toe since the amputation, because I saw him like 4 days later. So I was like, I don't know if that's dried blood or if this is gangrene, like what's happening here. So you can bet I'm getting very aggressively scanning around this toe. And he still has this occlusion here. The second dorsal metatarsal artery is kicking in with a really nice PAT. And so we communicated with the podiatrist that this is looking good, healing nicely. It was just some dried blood. But, when you get the full picture and you start to understand, that's really nice. So I have the privilege to be in the cath lab with Dr. Constantino and really use PAT to its fullest potential. And so we use it as an endpoint, as I've said, but really this is what we're after, is getting that change in PAT. And sometimes it's not always straightforward. Sometimes the angio doesn't tell the whole story, where we can put the probe right next to the wound and say, we're done. We have enough blood flow, which is really nice. Because again, we have this endpoint by the use of PAT that we know when enough is enough. So let's talk about what's new on the horizon. Napkin ideas can be so exciting. Well, that was talking about the veins of the foot, but I'm sure many of you are aware of venous arterialization or DVA. A lot of work has been done and a lot of publications, and it's pretty exciting. This is considered a no option or poor option procedure for patients facing amputation. And so we're basically creating a fistula between the artery and the vein. If you've heard of lymph flow, I'm sure, where they connect with a stent, and we are forcing flow through the arterial system across an anastomosis down the venous conduit, where we lyse the valves, and then we get flow around the pedal venous arch to then supply oxygenated blood to the foot. So ultrasound really is playing a nice role in this, or should, because we can help with the preoperative mapping. Maybe we can do a nice job of saying, this could be an option based on the arterial duplex, because there's no flow in the foot, but maybe we could make a connection in this posterior tibial artery to the posterior tibial vein. And ultrasound is very important because we're using it to gain access in the lateral plantar vein, because we need to get through and through access from artery to vein. And doing a lot of research now and about to get our paper submitted on pedal venous anatomy diameters, reflux. There's a lot to be understood about the foot veins and its importance in relation to venous arterialization. And then when we talk about Wi-Fi, so again, this is kind of emerging use, is, we stage our patients. However, sometimes staging can be limiting in the ischemia ring because there's no toe pressure, ABIs is abnormal or not reliable, and TCPO2 is unreliable. And, Dr. Mills, he's the next president of SVS. He too agrees that maybe PAT have a role in this ischemia ring, which is very exciting because we need to do everything we can to get our patients staged. So the multidisciplinary approach is really important. And I bring this topic up because of all of the sonographers, vascular technologists, we are all part of this care team. And it really takes a village. And we have models in place, toe and flow model. We also do a roundtable discussion in the Portland area where we get multi-specialists together to talk about cases. So if you have any interest about a multidisciplinary program in your center, please reach out to me. I'm super passionate about it. It's really just bringing like-minded, passionate people from all specialties to try to do our best to reduce the rate of amputation. So I want to bring this back to this patient I scanned yesterday. So again, she's 46 and she's had no intervention. She had ABIs that were 1.4, and I'll show you, I'm not sure why, but outside institution. So the podiatrist is calling saying, I'm really sure why this is not healing. You can see that one side of the wound is healed, but this is really staying open. Now, some of the issue is, her A1C is 11. She's not truly offloading. She's wearing this shoe. But if we really look at her ultrasound, her anterior tibial artery distally looks beautiful. But what I can say is that, yes, her PAT and her entire foot is class 1, but she has some anatomical changes. Her lateral tarsal artery is ginormous, feeding that side of the foot, and her medial or her dorsalis pedis artery is tiny. But when we look at our medial plantar artery, everything around it points to good flow. So this probably is maybe an infection versus, whatever. Not my role. My role is to just provide this information, but it can be very powerful because it lets everyone in the care team understand what's happening underneath that and why her foot is maybe not healing or why maybe it doesn't matter. Her blood flow is fine. So I found this case so intriguing because you just never know what you're going to find when you start scanning the foot. As opposed to this gentleman, this is a patient with multiple foot wounds, not so lucky. Like we've got some work to do with this one. So as I said, the perineal is fantastic. We were perineal obsessed and now we're heel obsessed. So I think we have so much room to understand and growth of discovery and research around the heel. So just stay tuned. Currently in the process of really trying to understand blood flow around the heel. So that's very exciting. Here is a research update. So we've concluded our multi-center international study data set. This is 4 centers, 3 locations around the world. And it's very exciting. So look for that publication in the year 2023. This is really looking at the diagnostic accuracy of PAT. And what we did is we compared PAT to ABIs, TBIs, arterial duplex, TCPO2. But the cool part of it is it was done with one vascular technologist goes in and scans an arterial duplex, ABI, TBI, TCPO2, closes out the study, and a blinded second sonographer comes in and does PAT because we didn't want to be biased. So I'm very excited about this publication that will be coming up. And there's many more publications and research happening right now around the world and in the US. So that's excellent. So in conclusion, is pedal duplex a possible solution to decreasing amputation? I think so. I think it's innovative. It improves patient care. It can be repeatable. It's accessible. We all have ultrasound. And it really ignites the excitement and the passion and the joy of our job. I mean, these patients are tough. So I hope that you found this valuable, and I certainly welcome the questions, but here's my contact information. Please contact me. Let's talk about it. I'm so passionate about it, and I want everyone else to be too. So thank you both Amy and Scott for the opportunity to speak, and probably can address some questions.
Awesome. Well, thank you, Jill. That was a fantastic presentation. Yeah, we have a couple of questions here for you. So I'll start from the top. In your earlier slide, you mentioned that post-amputation in diabetics leads to a 50% mortality rate within 2 years. Is this for any amputation, even just a toe?
That was referenced